FND Hope is a nonprofit patient advocacy organization for functional neurological disorder. And today we have Dr. Mark Edwards. He is a senior lecturer at the Sobel Department of Motor Neuroscience and Movement Disorders at UCL Institute of Neurology. He has also practices medicine at the National Hospital of Neurology in London. Also, another common question of confusion between the two, patient and doctor, are what are the key features of this disorder that confirm that there is a mind-body connection? What types of things? I mean, obviously this Hoover sign and some of those things that you mentioned, but there are people that have had, like seizures, for example. There's two types of non-epileptic seizures. One is from like physiological problems. You read on your medication all the time. If you have a seizure, contact your doctor. What's the difference between that type of seizure, non-epileptic, and the functional type?
It's a big question. I mean, I think that there are people who can have things which look like seizures, which are due to other, if you like, I suppose structural. I'm thinking basically about blood supply problems. So I don't know, somebody has a very low blood pressure, maybe from taking medication. They might faint because of that, but actually have some seizure type activity. So that's sort of that's not epilepsy. That's something a bit different.
Exactly.
But what separates these sort of functional non-epileptic seizures from that is that if you like, there doesn't seem to be all of the basic stuff is working. So you can do an EEG which shows that the person is awake and the brain looks like it's working normally, even though the person might actually be experiencing a loss of consciousness to them, or at least a blunting of their awareness. And you can check their heartbeat and you can check their blood pressure. Their heartbeat might be raised because they're having a shaking attack, but there'll be enough blood getting to the brain, their blood pressure will be okay. So all of those sort of physiological things are okay, but the experiences that the person's having is completely different. So I think that there are, if you like, positive ways to try and separate off functional symptoms from other neurological symptoms in a reasonably effective way for quite a lot of symptoms. That's particularly true of movement-related symptoms, like tremor, weakness, sometimes people having seizure-like attacks where you can show that by basically trying to talk the person down, so to distract them in some way, you can get an attack to stop, for example. I think for people with sensation problems, like I said in my piece for the website, it is a lot more difficult because there's no way of sort of distracting somebody and then asking them whether they've got normal sensation or not again. So in that situation, you would often try to investigate it a little bit further. You might, do some electrical tests to check that the wiring is basically working okay and the sensory messages can get up to the brain, even though somebody's got a limb which is anesthetic, for example. I think that all of those things I'm talking about don't really say anything about the mind in the way that people might think about the mind in terms of emotional things. And like I said in my piece for the website, that's because those things are not the way to make the diagnosis. That's not to say they're not important, but they're not a safe way on their own to make a diagnosis.
Which I think comes across for patients that there's kind of this sort of sitting on the fence type, because it's clear through research that there's not always a psychological connection that can be made, which was the original true conversion type. Was, I went to hit somebody, I shouldn't have hit him, or I knew I shouldn't, and my arm went limp. That is very clear. And I think it's important that they keep that, because it does happen. It's that phenomenon, too, that when someone gets in a car wreck, they broke their neck, they can get up and walk, 20 feet and then fall over before it all kind of comes together, I guess. Anyway, that's how I've kind of thought of it on both positive and negative. But
I think it's just, sorry.
Well, for when there's not that connection, for it to still be psychological is very, and the main focus to be psychological, I guess it just that how you guys have made that connection still is what the information that I think if people could understand that they could then comprehend. And I think there's always been this kind of hidden curriculum of that, and I'm not saying you, I'm saying in general, years over the past, that if we can trick them into doing something, then we can prove that, it is psychological.
Sure. I mean, I think that I think the first thing to say is that it's important to take a broad view of the ways in which this problem, or the triggers, or the ways in which this problem might arise. And so thinking about more direct things that people would consider as psychological, so traumatic events, difficult life experiences, depression, anxiety, those sort of things, that's very important. And if those things are there, then they deserve thinking about and talking about and so on, because they can be relevant. I think that there's a whole other way of thinking about psychology, if you like, which is that there are there's a basic, if you like, a basic machine, which is our bodies, and then there's a control mechanism on top of that, and that control mechanism is obviously influenced by emotions and that sort of thing, but it's not just emotions. It's also about specific ways in which the higher bits of our brain control movement, make decisions about what action to do now, make sort of basic decisions about what things to attend to in the environment, make decisions about which sensory information to pay attention to. Mm-hmm. And quite a lot of those things are not, they're not what people would usually think about when they're talking about psychology, but they are part of cognitive psychology, so that's a discipline in neuroscience. So there's another level of thinking about how the brain controls our experience from sensation to movement than just thinking about feeling depressed or anxious or that side of psychology. And just, I think, going back to the movement example, there are people who, you ask them to try and move their leg, and they're really trying hard, but they can't make it move. And when you get them to do it in an automatic way, then they can do it. And so I think what's happening in that situation is that they've taken a thing which should be automatic. So basically, even though we think we're in control of our movement, mm-hmm. we're actually not most of the time. It's just happening automatically. So these people are trying to control movement in an abnormal way, in a very conscious, deliberate way, and it's going wrong. And so actually helping them to recognize what they're doing, how the movement is going wrong, and then trying to train them out of doing that is a reasonable way to help. And that has nothing really about necessarily talking about depression or anxiety. That has all about how to, let normal movement happen and sort of let go, if you like.
Right.
And happen through physiotherapy, for example, of a specialist sort.
Right. Well, and which brings me, just for clarification, now, does movement come from the same spot in the brain, whether it is involuntary or voluntary?
That's a complicated question as well, but I mean,
because that instinct to fletch, to kind of jump back or something, is that coming from the same part of the brain as I'm gonna, lift your leg, please?
Not exactly. So there are some very basic reflex responses, like if you get a startle, for example. If you're going across a road and suddenly you see a car coming towards you and you jump back, that is happening at a pretty low level in the brain. But more normal movement that's happening, as we're going through a normal day, that has contributions from higher bits of the brain, but most of it is happening in a very unconscious way. So I'd actually say that the amount of the day that most of us would spend doing extremely deliberate, very attention-full movements is very, very small. Okay?
And
So most of the time, movement is just happening, and we're thinking about other things. So that's why I'm saying that what people may do with functional movement problems is something particularly abnormal. So they're trying to control all movement in a very conscious way, and that's what maybe makes it go wrong a lot of the time.
well, like
So
walking, for example, because if I asked, well, you probably would know because you know those things, but if I asked the typical person, show me how to walk, like teach
yeah,
me, where all of a sudden you go, well, I don't know, you put your foot
exactly,
down, you just walk because it's that
exactly.
innate ability. So now take someone that has had paralysis of some sort, and all of a sudden they stand up to walk, and they don't know how to anymore. And of course, that's where the physio comes in, as then learning that's like, okay, start at your toe, you're going to shift your weight, move into the heel, and that reteaching of the brain. So I guess what I'm,
So
go
yeah,
ahead.
okay. Well, I was going to say it's a good example really, because I think uh, that maybe it is the case that for people who've had a stroke, for example, you might start with some pretty basic bits of movement and trying to educate people in that way. But I think even there, people have moved away from trying to get people to really concentrate on every individual movement, and they're trying to get people as quickly as possible to start thinking about the goal of movement. So not where am I going to put my foot, but where am I going, kind of thing. And I think in people with functional movement problems, you can actually skip a lot of those early steps, and you can move on very quickly to try and getting people just back into the normal habit of walking. Um, I've certainly had experience of. I mean, I have sort of good luck to work with a really fantastic physio, but I had the experience of having people who've been in rehabilitation for some time, but they've been working at a very slow, very low level rehabilitation. Whereas actually, the physio I work with often gets people up onto a treadmill in a harness, for example, so they're supported so they can't fall. But just that experience of getting up, just getting some normal feedback, some normal movement back in a sort of without thinking about it way, can often really make a big difference to people. And suddenly people get their confidence back.
Well,
And then they can start to relax a little bit more with their movement, and then things start to snowball from there.
do
So it's
you,
really you're working at a slightly, I think, just trying to work at a different level in the nervous system. That's all. When you're working at quite a high level in people who've got functional movement problems, I'm talking about here, um, and just trying to get that automatic access to movement working again.
well, and I really think that that is more key what you said about the automatic
Mm.
is because obviously it is coming from two parts of the brain. It's all connected, but to say, take a step and then to put someone on a treadmill and start running their legs, there is an automatic kind of, I would think that those movements are going to come from different parts of the brain.
Yeah, they do. So that, in that sense, they do. And what you're doing really with automatic movement is you're turning off a lot of the sort of conscious bits of the brain which really have no business in movement. They have business in thinking about what am I going to do with my day, where am I going, what do I want to do. But they don't really have any business about the mechanics of how to do it. And you can think of that sort of analogy extends to things which are less sort of movement related. So things like speech, for example. So I see a lot of people who've got functional speech problems as well.
Mm-hmm.
So often in a sort of when they're not thinking about a conversation, their speech is quite normal. Then when they're in a situation where they're thinking about it, their speech becomes very stuttery, or even their accent might change, or they might be unable to speak at all. So that's the same thing. It's about sort of conscious bits of the brain getting involved when they shouldn't be. And on an even more sort of abstract level, um, quite a lot of people with functional symptoms have difficulty with memory and thinking at times. And it's often when they're trying to remember or think in a very sort of conscious way. And we all know this experience of, when you're trying to remember something, the worst thing to do is to try to remember it.
Yeah.
You have to do something else, and then it will pop into your head. So it's the same process. And I guess what I'm trying to say is that I think functional symptoms arise from a basic way that our brains are put together. So that we have this tension in our brains all the time between an automatic sort of machine, if you like, and conscious control. And most of the time, our automatic machine should be getting on with what it does. But when the two get a little bit mixed up, then that's maybe where people can develop these sorts of symptoms. And they're, as I say, of this particular sort where you can show that the basic machinery is working okay. It's just that people's ability to access it is not right. Now, exactly why that happens is a very difficult question and probably has lots of answers. But what I'm talking about really is how symptoms develop. And that's a slightly simpler question, and probably quite a lot more relevant to trying to develop maybe treatments and at least how to get a decent diagnosis, developing treatments, etc. I think.
Basically, because the thought is that it's the unconscious mind that is taking over, right? That's kind of the whole psychology connection, is that this unconscious psychological drive is taking over, yet it only affects our conscious movement. Does that not do you see how that doesn't feel like it correlates? How can you?
I agree, and that's why I don't really buy that explanation particularly. I think that there are. I think the way I would think about the unconscious side of things is that there are sometimes things that people are doing which they're not aware that they're doing. So, for example, I'm sorry for people who've got sensory problems and so on. I'm always talking about movement, but it's actually the thing I know best, and it's an easier way to give examples of it. But just thinking about somebody who's got a functional tremor.
Mm-hmm.
Often they're not aware of the fact that their tremor is being generated by attention towards the limb. So often when they're moving, when they're using their limb, you can see that they're looking at it the whole time. So they have this visual attention to the limb. And that's what's happening and driving their tremor. And so that's when, if you can show that to people, and you can show that, look, when you're distracted, when your attention's somewhere else, the tremor goes away. That can lead, in some people, to a realization of that and an ability to control the tremor. Not in everybody. I'm not saying it's easy, but those people weren't really conscious of the fact that they were abnormally attending towards their limb,
right,
and that was driving the tremor. So on that level, I can understand. I don't really necessarily buy so much the sort of repressed emotional trauma argument, which I suppose is where these unconscious drives are coming from, in sort of descriptions of conversion disorder and so on. I certainly think there are also people who, for whatever reason, I think sometimes it's because they've had bad experiences with doctors, are not really in a good place to recognise the fact that they have, say, significant anxiety,
right,
or depression. And I think that's sometimes because people only think about those things in a very psychological way. So they say, well, if I'm anxious, that means I should be feeling panicked and anxious about something, but I'm not really. But then when you talk to them, you say, well, how are you feeling? Well, they'll say, well, actually, my chest feels tight, my heart feels like it's thudding in my chest, I've got this sort of lump in my throat, and I feel like I'm breathing too fast. I often feel like I'm not quite there. I'm sort of dissociated from my surroundings, and I feel like I'm looking at myself from the outside. Those are all symptoms that psychiatrists would associate with panic disorder or anxiety.
Now, of course, they can often be other physiological symptoms also, and I think that's where that comes in as being, how do I know that it's not that?
Well, I think that's where, again, good clinical assessment is important. So, I've seen people who have been labelled as anxiety because they've had palpitations, so thudding in their chest, and then when they've had a recording of their heart, they've actually got an irregular heartbeat, for example. Okay, so that can happen. But there's an easy way to look at that. If somebody's got symptoms, you can record what their heartbeat's doing, and you can see what's happening. So it's not rocket science in that way to necessarily to investigate things and keep an open mind about the cause for symptoms. I guess I'm just saying that going back to your original question about these unconscious drives, I would say that sometimes it is the case that we're not aware of the drivers to the sort of state that we are in. Okay, so we're sometimes not aware that actually these sensations from the body could be related to, for example, anxiety or panic type responses, so fight or flight responses in the body. And sometimes when people become aware of that, they're able to control them better. But that's, again, not the story for everybody.